prevalence of this disease. Now, how does this happen? You see these two pictures, ectopic endometrium and ectopic endometrial cells. We have the hormones estrogen, which comes from the ovaries. The estrogens on the ectopic endometrium cells stimulates the immune system if the immune system is poor, and this endometrial cells, as you can see here, will undergo proliferation and differentiation and bleed. And this is happening because of the retrograde menstruation, which goes back, and then there is vascular or lymphatic circulation which attacks this retrograde menstrual cells, these cells, and then the stem cells get altered. On the other side, when it comes into the peritoneum, the menstrual blood, the immune system, if it is weak, if it is strong, it phagocytizes the thing. Otherwise, these cells will invade, cause oxidative stress, cause neoangiogenesis, cause chronic inflammation, and these cells will implant in the peritoneal areas outside the uterus, uterine lining. Could be uterine surface, could be ovaries, could be anywhere. And this is what causes endometriosis. So, this in nutshell tells you what is the pathogenesis of endometriosis. There is a theory about progesterone. Now, progesterone receptors are there. In a healthy endometrium, there are PRAB receptors which cause cell proliferation, desensitization, apoptosis, anti-inflammatory effect, anti-angiogenic, and menstruation. While in utopic and ectopic endometrium, the PRAB, which causes increased cell proliferation, impairs the desensitization, reduces the apoptosis, reduces the anti-inflammatory effect, so the inflammation, and causes increased bleeding, and that will lead to. So, in addition to the estrogen dependence of this disease, there is an increasing evidence to support that a profile of progesterone resistance in the pathophysiology of endometriosis might be there. So, that also we need to, because this will help in treatment of these diseases. What are the immunological changes occurred in endometriosis? Endometrial cells in some women express modified self cells. Persistence of these self cells are there, which will lead to chronic inflammation, damage to the nearby bystander cells, sensitization against the normal self antigens, and immunological suppression. This will lead to, as you can see in this table, it will go like that. The antigen exposure, that is these cells, destruction of the inciting stimulus, expression of epitopes, stimulation of CD4 and helper cells, the inflammation, activation of specific B and T type of lymphocytes, production of antigens, specific CD4, CD8 and T cells, and subsequent exposure will keep on increasing this. So, direct attachment of the antigen positive cells to the peritoneum or to the tissues, mobilization and activation of macrophages, natural killer cells, NK cells, and stimulation and secretion of mediators for inflammation, leading to chronic inflammation which may occur. What about the age? This disease is of reproductive age group mainly, predominantly, but adolescents and perimenopausal women also show endometriosis. Pre-adolescent, before the menstruation starts, the incidence is very rare. In reproductive age group, the incidence is highest in comparison to women compared with 25 to 34 and 45 to 54 as compared to 34 to 44. It is frequently diagnosed symptomatically sometimes in perimenopausal and even menopausal women, and there is enough evidence in gynecology, reproductive biology referral papers. What about lifestyle? Drastically decreased pregnancy rate as a direct result of modern women's lifestyle, including the availability of contraceptives. Contribution to an increased incidence of endometriosis is well established. So, women who do not conceive for a longer period of time and are delaying conception are more prone to have endometriosis. The cycling endometrium with more frequent menstruation can lead to endometriosis. So, if the menstruation keeps coming and there is no pregnancy to suppress for 9 months, that woman is more prone to develop endometriosis. What about work shift? Now, very interestingly, estrogen levels in women in reproductive age group follow a circadian rhythm in addition to the monthly ovarian rhythm, and may be vulnerable to the circadian disturbances. In fact, Night shift workers has shown effect of estrogen secretion and has associated with menstrual disruption and increase. So those women who are working the night at call centers, their disturbed sleep patterns are more prone to have endometriosis. What about toxins? Now, dioxins are associated with the spectrum of toxic symptoms on the reproductive, immune, and the endocrine system, endocrine disruptors. Clear relationship between dioxin exposure and the development of endometriosis has been well established both in rodents and in primate models. Lots of evidence, lots of papers about this. Linked an increased risk of endometriosis with elevated level of dioxins in the patient's serum. Again, very many studies to show that endocrine disruptors may be responsible for endometriosis. So to summarize, if you look at this picture, the endometrium is C3 complement HOX A10, A11, alpha beta integens, glutathione peroxidase, catalase, free radicals, aromatase, EBAF, interleukin 6, HGF, VEGF, and glycogen and mucins. Now, these are all there in the endometrium. And the menstrual blood will shed like this from this endometrium. So, now what happens is the VEGF angiogenic soluble when this occurs as a retrograde menstruation. So, this retrograde menstruation, if lands up into the ovaries, will bury, cause inflammation, and form endometriomas. It will also stimulate the cytokines and the growth factors, and these will activate the macrophages, will come and attack this. If the immune system is good, it will be moved. Otherwise, mesothelial peritoneal fluid, estradiol, IL-1 and VEGF, all these will act on this, and the endometriotic implants will occur and they will cause invasion. And when invasion occurs, the MMP and TIMP are activated, haptoglobin is activated, neovascularization occurs because of VEGF. So that causes the endometriotic implants in the peritoneum. This also starts the MCP1 rands and attracts the macrophages to destroy the retrograde endometrial cells. But if the immune system is poor, then the whole cascade of inflammation occurs. There is also an embryological origin of endometriosis. Analysis of about 101 human female fetuses interestingly showed that this research group showed that in a significant number of female fetuses, there were endometrial implants outside the uterus. So, this caused alteration in the fine tuning of the primitive Mullerian tube formation and could be one of the causes of endometriosis. This could be one of them. There is some papers to the tune of that. Then of course, there is the coelomic metaplasia theory, which is most controversial. Ivanov and Meyer's theory, which is called, we propose coelomic metaplasia theory, which explains that endometriosis may derive from the mesothelial cell through metaplasia. We know that we have the endothelial, the mesothelial cells embryonically, and when the mesothelial cells metaplasia, that can happen. So, this is proven by seeing that endometriosis, rare endometriosis occurs in male pubertal adolescent girls, distant endometriosis in thoracic cavity. So, this theory can explain that distant endometriosis. So, that could be one of the reasons. So, it comes to full circle. Three distinct stages, premenarche and adolescent. Two types can be distinguished: a classical form that occurs before menarche, and a congenital obstructive form is caused by the uterine anomalies and outflow obstruction, which will come to this. It suggests that the premenarchal and possibly the adolescent endometriosis developing is by the activation of the resting stem cells at the time of neonatal retrograde uterine bleeding. In adult, the endometriosis can be related to uterine preconditioning by cyclic menstruation acting as priming for the deep placentation. And in postmenopause can develop or be reactivated both in presence and absence of exogenous estrogens, and can spread to the variety of organs and the structures nearby.